Here's a brief agenda of what I would like to discuss. I will review shortly the system details and what this means in terms of patient comfort, the design of the machine, the low noise level, but also some advantages relative to other 3T machines in terms of quite homogeneous RF and FET set over a larger field of views. And I'll show some examples of some standard pulse sequences to give you a flavor of the scan quality that we are achieving at the moment, but also discuss some more advanced pulse sequences which we're starting to explore and trying to understand what their clinical relevance would be in certain disease indications. So a few pictures. This is just a typical scanner. You can see that the table can move up and down. It's a wide bore system with a not too long tunnel, which is obviously good for patient comfort to have the wide bore. As you can see here, the length is not very long, so it's not a claustrophobic machine, and the patient table can move up and down conveniently. This is actually the site hosting in our hospital. We put it in a room where previously a 1.5 Tesla was, so it easily fitted in there, so it doesn't have huge space requirements. Some specs, so it's very low on helium, as I mentioned already, the wide bore and the relatively short length of the bore. B0 homogeneity, which is good over a relatively large field of view, despite the short length of the bore. So that allows you to do relatively large field of views, which is good for spine imaging, for example, which can be challenging, as you might know, at 3 Tesla. Then the transmission is multi-phase with 2 RF amplifiers, but 4 transmission points, which is good for the homogeneity of the B1 field. And the gradients, we currently have a system with 30 millitesla per meters with a 200 slew rate. And what is particular feature of the Toshiba systems in general, but also for the 3T, is the relatively low noise level, which is maintained through all sequences. So not for specific sequences, but for all sequences. And has to do with the design of the gradient system, where the gradient coils are put in a vacuum chamber and also have some sound dampening material. And so the vacuum chamber cancels airborne propagation of waves, and the solid structure cancels direct propagation. So together you get a relatively quiet system, independent of the type of sequence that you run. The other thing is the FET saturation, which is quite homogeneous. Often the field is not homogeneous enough to do a simple spectral FET suppression, because the frequency shifts depending on the localization in the body. So if you do a simple uniform FET suppression, you may suppress some parts, but others you won't, or you actually suppress the water signal. Whereas if you do this slice selective, you get a much more homogeneous FET suppression. It's called MSOFT in Toshiba terminology. And here's some examples from abdominal imaging. And you may appreciate the very homogeneous FET suppression achieved over a relatively large field of views in coronal and transverse planes. Here's another example, just to give you a flavor of the homogeneous FET suppression throughout the abdomen, which is otherwise sometimes difficult to achieve, especially at 3T. For the lumbar spine, this works equally well. So with a surface coil, you can see this is a two-weighted fast spin echo with FET suppression very nicely suppresses the bone marrow signal over the field of view. More general, I think the signal quality is rather homogeneous over a large field of views. And for those of you who are working with 3 Tesla, you will recognize how difficult it is to make good quality spine images over large field of views, and we're quite happy with the large field of views that we can achieve with good quality in T2 and T1 weighted images. Here's a zoom up with a slightly higher resolution, showing you some exquisite details of the vertebral discs and a small disc extrusion seen at this level and this level. And also notice the good quality T1 spin echo, which again is something that is oftentimes difficult to achieve on 3 Tesla systems. Here's a C-spine with an inversion recovery prepared T1 and T2 fast spin echo with JET, which is the motion correction algorithm, which helps to improve image quality in certain areas. So the big question, of course, if you have a free T, is what to do with it. And people have looked at the diagnostic relevance of free T and done a meta-analysis and said, well, it's actually quite difficult to prove the advantages. And we slightly jokingly wrote a commentary on that because, you know, the advantage or disadvantage of driving a sports car, you know, if you would have the money and the roads are good, you know, why would you not drive a sports car if it's not that expensive? But the question is, of course, what to do with the free T. So you can drive very fast, but you can also, and save time. But you can also say, well, I spend more time and I want better resolution. So let's start with the first one. If you say, well, I have a better car, you know, let's do it quick. So here's an example of some very common sequences that you can run in very low scan times on the machine. So for a standard protocol, standard brain protocol, you can do this in 5 to 10 minutes. Here's some more examples of DWI, ADC, T1 in 2 planes, and you can see the acquisitions are all very short. Obviously, you may also say, well, you know, I have a very good car, so I want to, you know, not drive very fast, but very precise on a special roads. Let's say you're driving up a mountain, and you need your sports car to be very precise. Well, you can also say, well, spend a little bit more time and take advantage of the higher signal to noise to increase the spatial resolution. And these are 0.3 millimeters in plane resolution pixels to look at the pituitary, and you can see the exquisite detail in the image that's achievable. The JET I already mentioned, it's the Toshiba implementation of motion correction, so playing around with the acquisition scheme to eliminate motion artifacts like this, and getting good quality images in reasonably short scan times with either T2 or FLAIR type of contrast. Also applicable to the cervical spine, I already showed you an example. You can get nice quality images by eliminating the movement artifacts. So, as I said, you know, there's a couple of things. If you talk about free T, wouldn't we all like to drive in a sports car? But then, thinking more broadly, you know, what is the holy grail in diagnostic neuroradiology? Is it free T or is it 3D? So this is another slightly provocative commentary that we did for European Radiology at the Centennial. And I think actually, you know, if you have the high signal to noise, why not work with 3D imaging all the time? So if you acquire the images with a high resolution in 3D, it will allow you to reformat in any plane possible all the time, which is what you want, because otherwise you have to acquire images in multiple directions, which will take time. So FLAIR and T2, you can acquire isotropic voxels with something called MFOX, which is similar to Cube, Space, and Vista that you may know from the other vendors. So it's a very long echo train, single shot, turbo spin echo sequence, which allows you to do 3D encoding in a reasonable time frame. Here's some examples. I hope it shows T2 weighted images of a child with polymicrogyria. You can see missing corpus callosum, but also very exquisite detail of this malformed cortex, which is extending here in the frontal lobes. You can see on the coronal reformat from the sagittal T1, and so you can get multiple contrast in short acquisition times and then reformat in any direction you want. Likewise, for MS, one of our specialties, we use the 3D FLAIR all the time. Notice that we apply a fat saturation to the image, which makes the image very nice and quiet to evaluate. I'll show you a movie of this case. So do focus on this lesion, which is here in the internal capsula, seen on the FLAIR on the T2, which is then causing Wallerian degeneration in the brainstem. And on top of that, you will notice that with the 3D at 3T, that the FLAIR also is quite nice at looking at lesions in the posterior fossa and in the spinal cord even, something which may be difficult at 1.5 Tesla. Let's see if the movie works. Okay, so here we go. Hope you can see it. So you get these very thin slices going through the brain. Notice the very homogeneous fat saturation again. And we're starting to see this lesion. This was the large lesion in the internal capsula and causing the Wallerian degeneration through the brainstem, and some other typical lesions in the periventricular white matter and in the corpus callosum. And here was a juxtacortical lesion. Let's play this once again. Hopefully succeed. So the symptomatic lesion is in the internal capsula here in a second. And you will notice the Wallerian degeneration going down in the spinal cord over here. And then multiple lesions in the cervical cord, multiple periventricular lesions, and a lesion in the cerebellum. And at the end, you will see a juxtacortical lesion appearing here, over here. So this, very nicely shows you the details, and you can reform it in any plane and review. Here's, for example, another case with MS with very impressive lesions, tumor-affective MS, and oftentimes these patients can get biopsies, which are obviously not indicated, with very big lesions seen in the FLAIR and the frontal and occipital lobes. Here's a transverse reformat from that same data set. Beautifully shows the lesion again in the optic radiation, enhancing with gadolinium. And this is another feature to notice, that on the Toshiba system we can get reasonably good T1 spin echo, which is, perhaps a humble achievement, but it's actually very difficult to get good T1 spin echo images at 3T. I think the system does very well. I'll show you some more examples of that in a minute. Here's another type of pathology, a young girl with tuberous sclerosis and epilepsy, and she has multiple tubers in the juxtacortical white matter, which you can see on the reformatted MPRs of the FLAIR, and on the better, of course, than on the T2 scan. This is our protocol to look at tumors and at infections. And again, the FLAIR was done in a sagittal fashion and then reformatted in a transverse plane with T2. Notice that at baseline there was diffusion restriction in this abscess, which was treated conservatively with antibiotics. And at follow-up, you can see that the low ADC has disappeared. It's actually high ADC at follow-up, so successfully treated with antibiotics only. Here's from the same case the T1 weighted images. So this is a coronal reformat from the sagittal T1 and then axial T1 spin echo before and after contrast. Notice again that is good quality T1 spin echo, which is difficult to achieve usually at 3 Tesla. As I promised, I will also discuss some specific sequences that are unique to the Toshiba system, and many of them revolve around MR angiography and flow-related sequences. So, for example, it's very good quality time of flight, MR angiography, but also a combination of time of flight with a sequence called FSBB, which I'll discuss in a minute, which enhances the flow in signal by dephasing gradients. And a nice feature is the dynamic ASL, where you can do 4-dimensional mapping of flow in the brain. Let's go through them. So MRI, just standard TOF. You can go for high resolution, of course, because of the high signal to noise, and get beautiful images like this at a 300 micron resolution in plane. But you could also say, well, I don't need that much detail. I didn't want to do it quickly and get very good quality circle of Willis images in just over a minute and a half. This is the additional contrast that Toshiba provides, which is the hybrid of opposite contrast, or HOP MRA, which is a combination of TOF and the FSBB. And notice that compared to the standard TOF, there's increased visibility of slower vessels, slower flow in branches that are more distal, and you start to see a lot more of these M2 and M3 branches, for example, compared to the standard TOF. And this is a patient who had, by the way, who had a stenosis of the ICA and then had a bypass from the superficial temporary artery to the MCA. Obviously, here you can already see that it's connected, but with the additional sequence, you can see much better the peripheral branches that are filled by the bypass. This is the time-resolved MRA. Let's go back. So this is an ASL type of image, a perfusion type of image, where we look at the very early pass of the signal. Usually you don't want to see that. Usually if you do ASL, you want to see the parenchyma and look at the perfusion of the parenchyma, but if you make short delays, you will get an MRA effect. So if you and collate these images over time, you can nicely see the flow going through the arterial system, much like a routine TOF. And this can be used to look at the dynamics of pathology. So here's a nice case. Dr. Toshiba in Tokyo gave me this case, where you see that this patient had an occlusion of or stenosis of the M1 branch. You notice that early on there's already filling of the M1 and the M2 branches on the right side. And then if you have a longer delay, so here's a short delay, and you increase the delay time, you can see that you can actually track the labeling going through the arterial system, seeing the peripheral branches. And notice that on the abnormal side that there's enhanced delayed flow in collateral branches. So apparently the patient is trying to compensate for the stenosis here by using the collaterals, and obviously it takes more time to fill them, and with the dynamics of the 4D ASL you can appreciate that phenomenon. Another very unique sequence for the Toshiba system is the so-called FSBB, flow spoiled black blood sequence, which is a sequence that has some angio effects, but also has additional gradients to dephase signal in slow-flowing vessels. You can very nicely appreciate the veins, like in an SWI, but also in the arteries. And this movie, you can see the lenticulostriate arteries filling out very nicely, something that you wouldn't see on a normal MRA, of course. So this sequence provides good detail of the venous system, but also the artery. So it's a bit of a combination of an angio, looking at the arterial branches and the veins. And on top of that, you can look obviously for susceptibility artifacts caused by hemosiderin or calcification. This is a patient from our memory clinic with CAA, amyloid angiopathy, and these people have brittle vessels with small microbleeds occurring. You can see some here, and they also have white matter lesions, which may be very deep in almost subcortical positions. And here's again is a movie of the FSBB. This is a MINIP now, so minimum intensity projection of the data set that I showed you. So notice again, we see the veins, we see the arteries, and then on top of that, we see the multiple microbleeds, like here in the brainstem, the cerebral, and often in a lower position. Notice that there are multiple of these microbleeds, consistent with the diagnosis of CAA. Obviously, you can use this for cavernous angiomas. Here's a cavernoma in the right temporal lobe with a subbubble appearance on the T2 and a high signal on the T1, and the susceptibility effect seen on the FSBB. Notice that the spatial resolution of the FSBB can be very high. Here's a possible application. We haven't looked into this systematically, but other people are starting to do that to see whether SWI or FSBB type of sequences can be useful in tumor staging or grading. Notice that some tumors may have some high signal on T1, perhaps related to calcification or blood, and you can see that on a T2 star weighted image already, but on the FSBB you then start to see much more abnormalities and also more abnormal vasculature, perhaps neovasculature, which of course is one of the pathological features of a GBM. Other things can be of interest for GBMs as well, especially perfusion sequences. I'm going to show you some examples of ASL in a GBM in comparison with dynamic susceptibility contrast. This is a very interesting case that I got from Dr. Toshiba, where there's a patient with a GBM who then had contralateral neurological abnormalities and turned out to have an acute MCA occlusion with a stroke of the anterior MCA territory, so dual pathology. And here's the time of flight showing that the M1 is occluded with no runoff here. And the DSC and the ASL both show obviously increased perfusion in the GBM consistent with a high-grade tumor, but notice that there's very low perfusion on the right side as you would expect. So unique combination of pathology shown with both. And obviously, we need to understand better what is the additional value of ASL versus DSC. I must admit that a couple of years ago, I was not too interested in ASL in this indication because we're giving contrast anyway. But in fact, the ASL doesn't suffer from the typical leakage of contrast that you have in tumors. So with normal DSC, you're trying to compensate for the leakage by fitting a gamma variate curve. But in fact, ASL doesn't suffer from it because there's no leakage. You just look at the direct perfusion without any need to correct for leakage space problems. So I think there may be a future for ASL in the end for grading tumors as well. Here's another example of tumor grading. 50-year-old male with a GBM again, enhancing tumor with necrotic center. And again, I show you the comparison of the DSC with gadolinium, where you can get CBF, CBV, and MTT maps. But with the ASL, you can similarly pick up the increased perfusion. And also you can look with multiple delay times to characterize the flow better and get a quantitative estimate from the ASL, which may be in the end perhaps more accurate than what we obtain with DSC. Obviously, 3T is also nice to do spectroscopy, and we're just starting to explore the spectroscopy on the system. Here's an example from the CSI in this patient where you can look at the variability of the spectra within the tumor, very typical phenomenon, of course, for tumors. So in the center you have very high lipids, and all along you see reduced Na, of course, an increased choline, consistent with the diagnosis of GBM. So in summary, the system has, I think, high patient comfort. Patients appreciate the openness of the system, and also the relatively low signal level. Despite the smallness of the bore, there's quite homogeneous large field of view with good homogeneous RF and fat saturation. So together this leads to a rather wide range of clinical applications. We use it for MSK work, abdominal, but in the neuro field you can do spine relatively well, routine head, of course, ENT because it has homogeneous fat suppression again, and some advanced neuro applications that are unique to the system that I mentioned, especially due to some pulse sequences that are not available on other scanners like the FSBB. And for example, the dynamic ASL, we're trying to explore, for example, to better map AVMs and find the nidus of AVMs that you may want to radiate. And then finally, I'd like to finish by a slide from the inaugural session that we have called the Kagami Biraki. So if you deal with Japanese companies, there has to be sake. So when the system was inaugurated, we had to dress up like this and then hammer down a big pot of sake, and then we had to finish it, of course, as well. So that's the pleasant additional feature. And this is Kees van Kuiker, head of department, and Phil Sheltons of the Dementia Center. Thank you for your attention.